Hi, my name is Gary Gold. I'm the director of the PHIND Center. First, I'd like to call your attention to our upcoming PHIND seminars on June 15th from 11 to 12. We're going to have Pablo Paredes, who's a clinical assistant professor of psychiatry and behavioral sciences. And then on July 20th, we're going to have Alberto Soleo, who's a professor of material science and engineering, give our talks. Today, we're delighted to have Manuel Garcia-Toca, who's a clinical professor of surgery and chief of the Division of Vascular Surgery at Santa Clara Valley Medical Center, Stanford Healthcare. Dr. Garcia-Toca earned his medical degree at the Universidad Anahuac, in Mexico, 1999. He has a master's degree in health policy from Stanford. He did his general surgery training at Mass General and Brown University in 2008 and a vascular surgery fellowship at Northwestern in 2010. And he's board certified in both surgery and vascular surgery. Manuel joined Stanford Vascular Surgery in 2015. And he previously served as an assistant professor of surgery at Brown University. His research interests include new therapeutic strategies and outcomes for the management of vascular trauma, cerebrovascular diseases, dialysis access, aortic dissection, and aneurysms. Today, Dr. Garcia-Toca will be speaking with us about improving abdominal aortic aneurysms detection and screening. Manuel, thank you for joining us.
Thank you. Again, thank you very much for the opportunity to present our work. We've been working in this project, Dr. Alami and me, for the last 2.5 years, starting 2018, and with the help of PHIND, we've been actually successful on getting a lot of data and interesting the findings that I'll present to all of you. I don't have any disclosures, same as Dr. Alami. So interesting enough, last Sunday, it was the 65th anniversary of the death of Dr. Einstein. And this was the probably the first time that a lot of awareness was created for rupture aortic aneurysms. You can see in this New York newspaper how it says that a burst artery proves fatal to the physicist. Einstein died from a rupture aneurysm. He didn't seek any care because he had a previous repair 8 years before by Dr. Nissen, where they wrapped the aneurysm with cellophane to try to create fibrosis. But yeah, it's interesting that exactly, I mean, 2 days ago was the 65th anniversary. So abdominal aortic aneurysms is the 13th leading cause of death in men in the United States. Yeah. The prevalence has been going down. It used to be the 11th cause, now it's the 13th cause of death. The aneurysm ruptures are responsible for almost 10,000 deaths in 2018. There's really good data coming from the Veterans Affairs Hospital regarding aneurysm disease, especially from the ADAM study group, that it was the aneurysm detection and management. And it was almost like 25, 30 years ago that they were able to prove that smoking, it was the highest risk factor to the development of aortic aneurysms, same as male sex and a positive family history. And based on this is why the guidelines for aortic screening were created. So why screening? So the screening for disease is a key component of modern healthcare. The rationale is simple and attractive to we screen to detect diseases early in asymptomatic individuals and to treat them in order to reduce morbidity and mortality and all the associated costs. However, the role of screening often comes into question. There's some controversies and regarding overdiagnosis and overtreatment. Why screen for aortic aneurysm? Well, in the presence of a rupture aneurysm, the surgical mortality is 50 to 80%. And unfortunately, these aneurysms are asymptomatic. I mean, most of the time, people don't have any symptoms. Once they have symptoms, it's an ominous sign. And when we fix these aneurysms selectively, actually the mortality is less than 5%. In recent series, it's less than 2% with new technologies like endovascular repair. So it makes sense to screen. How do we screen? We use ultrasound. Ultrasound has been shown to be simple and safe. There's no radiation exposure, and there's high sensitivity and specificity for the detection of aneurysm in the aorta, and it's cost effective. There's level 1 data on the effectiveness of aortic screening. There's 4 randomized prospective trials in the literature that now they have over 10 years of follow-up, some of them 15 years of follow-up. The largest of them was a multi-center aneurysm screening study, the MASS study done in England. They enroll over 60,000 patients and divided on screening and no screening and then follow them. Then the Chichester studies was the first of all these level 1 trials, and that was in the United Kingdom too. The Viber County screening study done in Denmark, and the Western Australia screening study from Australia. The prevalence in these studies, it varied from 3.9 to 7.2% of the people screened. Several meta-analyses have been done based on these 4 trials, and the last one done and published in JAMA in 2019 that it was used to create the guidelines showed that regarding aneurysm mortality, when you screen, there's a significant value on screen with a P/OR of 0.65. And same for rupture. There's a significant decrease on the risk of rupture when you do aortic screening with ultrasound with an odds ratio of 0.62. The number needed to screen is 305 men to prevent 1 death and 246 men to prevent 1 rupture. Regarding overall mortality, unfortunately here, depending if you use odds ratios, there's no significant difference in mortality. It reaches 1 and with a relative risk of 0.99. So when hazard ratios are used to create this meta-analysis, these difference, it reaches a statistically significance, but it's still controversial if aortic screening actually has an impact on overall mortality. Regarding interventions, so when we do screening, the number of elective interventions increase, not surprisingly, but the number of emergency interventions decrease. So over the 13 to 15-year follow-up, these meta-analysis demonstrated that one-time screening of men aged 65 to 75 years is associated with a decrease of AAA-related mortality, decreased AAA rupture and emergency surgical procedures, and with a question if there's any impact on all-cause mortality. So because of these findings on these 4 trials in 2005, the United States Preventive Task Force established the guidelines, and they have been updated. The last one in 2019 it has a grade B recommendation for men aged 65 to 75 to have a yearly ultrasound screening if they have a history of smoking. A grade C recommendation for non-smokers. So it depends on the clinician considering the balance of benefits and harms to recommend the screening. With women that have smoked, the recommendation is D class, and an I statement for I statement for women who have smoked, and this statement, so meaning is not recommended to screen on women that have never smoked. So after 2005, that the USPSTF made their recommendations, Medicare began coverage of aortic screening under the Screening Abdominal Aortic Aneurysms Very Efficiently SAVE Act. The problem with the SAVE Act is that the coverage, the way it started was that it was only men 65 to 75 years of age who have smoked in their lifetime, and only as part of the Welcome to Medicare package. So it was a one-time off when you're welcome to Medicare, and if you were not screened, then you were not eligible. So because of this, after the first year of starting the SAVE Act, they in 2008 they looked at the numbers, and actually only 1% of the eligible of Medicare patients were actually screened. So it was not an effective policy. So this was changed after a few years to try to include more patients and not just the Welcome to Medicare. Contrary, the Veterans Hospital also started a program in 2007, but their program was more inclusive. It was not just a one-off. So the VA, what they did was they included all the eligible patients, whether new to the VA system or already enrolled in the system, that had a history of cigarette smoking, men and women. And so the rollout was much more inclusive. We have data on the regional effectiveness of the program at the VA from Northern California. The group from Dr. Chun, they look at the 1 year, 5 year, and 10-year data on Northern California, and they were able to get an incidence of aortic aneurysm on their program of 7.2 on the people who were screened. The majority of there were small diameter AAAs with only 6.6 being larger than 5.5, and they also found that there were a few, 28% of the patients had inappropriate screening, meaning that they were out of that age group or that they were non-smokers. Recently, they published the 10-year data, and it's interesting how if you look at the cause of death, most of the patients actually died not from aneurysm-related pathology, but from cardiopulmonary causes. And you can see how the survival curve on the people who had a normal screening versus AAA screening, how even though these patients were treated, the AAA or aneurysmal disease is a marker of survival. So at 5 years, 30% of the patients unfortunately died regardless of treatment. So in 2019, when the USPSTF came up with their new guidelines, they also outlined research needs that they need to happen. One was that more epidemiologic studies on the current prevalence of AAA are needed in the United States. Two, that we need studies examining systems approaches to improving the implementation of evidence-based AAA screening in the United States, given what happened with the SAVE Act with Medicare, that the actual uptake was really low. And also we need studies that examine the efficacy of screening and treatment in diverse populations. So given all this, I mean, even though we started a year before these recommendations, we were already, Oliver and I, working on this. And what we were trying to do is, it was looking at, given that the VA has a electronic medical record that's been present for, I mean, decades, that we were going to be able to examine the national uptake of these programs. So our aim with this study was to evaluate the efficacy of AAA screening at the VA, and looking at 5 years before the implementation of the screening program and 10 years after, and looking at the effect on overall mortality and the detection rate. We wanted to look at the percent of aneurysms diagnosed with screening, and if they were appropriate screenings, and also looking at the percent of aneurysms detected with other abdominal imaging. What was the regional variation, the overall mortality, and also looking at aneurysm rupture. The benefit of doing this study at the VA is the veterans have a high prevalence of smoking and makes a really homogeneous cohort. And smoking is a strong risk factor for AAA, as I mentioned before, based on the ADAM trial. And the extensive network that the VA has, we can capture patients across the country, and we can identify these geographic variation. And also, with the electronic medical record, as I was alluding, of more than 20 years, we have long-term follow-up. So we got approval for this project from Stanford IRB and from the VA Research and Development Information System, and using the DART, here is the code. We use the VA Vinci database, and our date of study was from 2000 to 2018. The benefit of is that aortic screening has two dedicated CPT codes. The G code 0389 was created after the SAVE Act, and it's a specific CPT code for aortic aneurysm screening. 4 years ago, a new code was created by a multi-specialty group to increase reimbursement, and this is 76706. So we have two dedicated CPT codes that make just teasing out which patients had an aortic screening much easier. Regarding our non-screening cohort, was abdominal imaging in 2018, ultrasound, CT, and MRI. And here are the CPT codes that we use. And for AAA diagnosis, we used two different algorithms. The first one was one created by the group in Ottawa that requires looking at the actual report and using this algorithm. The problem is that there was no access to almost like 20 to 30% of the actual report, so we couldn't implement this algorithm. So we ended up using an algorithm already validated by Denny twice, one in 2013 and one in 2020. What the algorithm does is that it uses the ICD codes and ICD-9 and ICD-10 codes in the electronic medical record. They need to be implemented twice, so you basically have the AAA diagnosis. The only thing that we did different with the Denny algorithm is that we limited the AAA diagnosis to 0 to 365, so basically 1 year, right? So we eliminated cases that were diagnosed before the index study. So we want it to be a diagnostic study, and we limited to 365 days to prevent that another study was done and a new aneurysm was diagnosed. I mean, by limiting to 1 year when the AAA diagnosis was imputed, we're probably underestimating the true prevalence, but we believe that this would make a more accurate AAA diagnosis rate. So these are the gross numbers. We were able to identify 322,042 aortic screenings. And of these aortic screenings done from between 2007 and 2018, we excluded 2,852 studies because they had a AAA diagnosis present before the index study. And on the studies that we studied, we found on an overall 4.84% AAA diagnosis rate by aortic screening that goes along with what is reported as a prevalence in the recent literature. In our abdominal imaging cohort from 2000 to 2018, we studied over 3.5 million patients. We excluded almost 50,000 patients that had a AAA diagnosis before the index study, and we found our AAA diagnosis by CT of 2.3%, with MR of 0.2%, and with ultrasound of 0.74%. That doesn't mean that obviously that the aneurysm was not present, because obviously what the significance with this is that the aneurysm might have been present in the report, but it didn't translate it to the electronic medical record. That is the important part, because that's where patients get follow-up and therapy. Here is our graph on the different types of studies and which patients were positive. I want you just to focus first on the red part, that is the ultrasound screenings. You can see how the in the red and blue are just ultrasound screening on the left and ultrasound on the right, and how, I mean, definitely more abdominal ultrasounds for other reasons were done. And how the uptake of aortic screening after 2007, it was implemented well and has maintained the numbers have been maintained over the last decade, with not a huge drop. That speaks well of how these studies were done at the VA. One of the problems may be that a lot of these ultrasounds may be miscoded, and you can see how after 2007, the number of the abdominal ultrasound went up. I mean, we don't know if this is related to the aortic screening policy, but it's interesting that after 2007, abdominal ultrasound went up at the VA. So one reason could be that a lot of these ultrasound screens were miscoded and just are abdominal ultrasounds. Here in this graph, you're seeing the number of aortic on the orange line is the AAA diagnosis and versus the number of studies performed. You can see that the prevalence of has been going down along the years. It corresponds to what's been reported lately with the decrease on smoking and increased use of statins, that the prevalence has been going down. Here is with other abdominal imaging, the decrease in AAA diagnosis is more drastic. And when you compare both the screening versus no screening, you can see that these lines are parallel, and how the prevalence of aortic aneurysm disease has been going down along the years. Here's all the abdominal imaging at the VA from 2000 to 2018. On red is the ultrasound screen. You can see how it's a really small percent of the studies are ultrasound screening compared to ultrasound in blue. In green is MRI, and in dark blue is CT scan. But when you see the AAA diagnosis, the percent of diagnosis done by ultrasound screening is much higher. But even then, the number of AAA diagnosed by other imaging is still higher than the actual aneurysms diagnosed by ultrasound screening. So we still have room to grow in terms of the diagnosis of ultrasound that needs to be done by screening. Still, I mean, even today, the number of aneurysms detected incidentally are higher than the aneurysms detected by screening. In our cohort of aortic screening, obviously because it's the VA, most of the veterans aged 65 to 74 are male. So 99% of the patients were male. In 1,000 patients, were female, and I'll show you the rates of aneurysmal disease by gender later on. But most of the patients were white, but we do have some data on the difference in race and aneurysm detection. I mentioned that the guidelines at the VA are that screening should be done between the ages of 65 and 75. So you can see how in 87.4%, screening was done adequately, but there was a 12% of the patients that were outside of the guidelines. So from 50 to 89 years old that got an aortic screening. The VA, one of their subdivisions is to divide it by district region, and with 5 different districts. You can see how most of the aortic screenings were done in the North Atlantic, 30% of the studies, and only 12% on the continental US. It goes along on the number of VA of the veterans per region. So there was not a big discrepancy in terms of the denominator by region. But I know this graph is difficult to see, but I just wanted to point out, when you go more granular and you go by actually the VA center, so there's 170 VA centers in the country. So, and here are the number of aortic screenings done. There's actually a lot of variation on the number of aortic screenings. And actually, when you point out more, 20% of the aortic screenings were done only on 5 centers. So there's another area of improvement, and one of our future projects to look at why there was so vast variation between centers. In terms of the AAA diagnosis rate, with aortic screening, you can see as you age, the rate of AAA diagnosis goes up. It's interesting that in the 55 to 64-year-old group, the rate was higher in the 4.5. This may be a specific population that actually got the AAA screen because they had a clinical finding, or they have a family history, and that's why the rate is higher. But yeah, it's interesting that in that subgroup, the rate was higher of AAA diagnosis. AAAs are more common in white males with a rate of 4.7, and interesting, we found in those 1,000 female patients were screened that the rate is 3.78. That is higher than what is reported. It's been reporting females to have a AAA diagnosis rate between 1 to 2%, and we found it 3.78. So this, I mean, just pushes that maybe the actual USPSTF guidelines should include the females as a better grade recommendation. In this survival graph, you can see how, as I was pointing out in the previous graph, how AAA is actually a marker of survival. So on red, you have patients that had other abdominal imaging with a negative AAA, compared to the patients that had a negative imaging with ultrasound screen. Their survival was poorer, meaning that, I mean, the patients that got other abdominal imaging, they're either sicker or they don't seek that much medical care. And that the actual screening subpopulation may be a cohort of patients that, because they get screening, they're more compliant with medications or visits to the hospital, and that's why their survival is much better. But when you look at patients that have a positive AAA, there was actually a significant, you can see on the curves, a significant difference in the patients that had a AAA diagnosed by screening versus patients diagnosed incidentally. On the purple line is the patients that had an ultrasound screening with a AAA positive, and in the yellow line is the other abdominal imaging. You can see how there's big diversion of those lines with a significant difference. The age group also plays a place in terms of survival. So obviously, older patients with an aortic aneurysm, their survival is poorer, and that's why a lot of these screenings are focused on the 65 to 75 to have a bigger impact. And when we look at the hazard ratios in terms of age, they just keep increasing, and with with really poor survival on patients that have a AAA and are older than 85. We look at the patients with, here is the patient that had a AAA, with no screening abdominal imaging versus abdominal imaging and versus ultrasound screening imaging. And what I wanted to point out is that the current smoking, it was really similar between the two groups. Almost 60% of the patients were current smokers. And that we created a Charlson Comorbidity Index, and it was similar between the two groups. So in terms of comorbidities, they were similar. When we did the causal regression analysis of these patients, actually ultrasound screening, their hazard ratio was 0.45, meaning that the mortality the survival was much better on the patients that had an ultrasound screen and a AAA diagnosis. When we look at mortality by age group, there's still those curves diverge depending on if you had an ultrasound screen in blue versus a other abdominal imaging, independently of age group. Obviously, the more you age, those curves diverge more. Our main analysis was a difference in difference. So we used 2007 after as our before and after policy implementation. Here is for aneurysm detection rate. So on this difference in difference, you can see on the blue line, the thin blue line is CT and MR, and you can see how the line doesn't, just goes down as it should, and as I was showing you before in terms of aneurysm detection. Here is ultrasound screen, but when you do a difference in difference, you need a control group. So we use ultrasound as our control group, and just the change in potency when ultrasound screening was done showed a absolute difference of 1.55% on detection rate when aortic screening was implemented. So more aneurysm was detected after the policy started in 2007. Regarding mortality, there was also and here the effect was much larger. So the absolute difference in mortality after policy was implemented in the difference in difference analysis is 13.8% for the patients that had ultrasound screening. So versus the patients with CT/MR. Obviously this difference is not just because secondary to aneurysmal disease. Most likely this is more secondary to best medical therapy on the patients that got a aortic screening, or they take care of themselves. We look at our rupture risk, and the patients that had other abdominal imaging, the rupture risk was higher. Not surprisingly, because these patients were not followed that closely, and the rupture risk for CT/MR was almost 4% versus only 2% on the patients with our ultrasound aortic screening. Luckily, the rupture rate was not as high. Could be also, there's some bias on the VA, because a lot of the ruptures don't actually go to Veterans Affairs hospitals, and they go to other hospitals. But still, there was double the rate of rupture risk on when you have an ultrasound screen versus a CT or MR. In the patients that rupture, there was also a significant difference on survival. If you have a rupture and then your aneurysm was detected by screening, you do much better than if your aneurysm was detected by CT, MR, and ultrasound. I'm not sure why is this difference, because both patients rupture. We assume that it could be related to more awareness, and these patients, because they know that they have a AAA, the diagnosis of rupture is made quicker versus the patients that have CT/MR ultrasound. But it's one of the things that we should be looking in the future, why this happened. We look also at when we're looking at mortality, what was the cause? So we look at the smoking status on our population, and it's for smoking, what we use, we queried using a 3-category of it's a smoking algorithm, and investigated with ICD-9 clinical modification codes. Unfortunately, smoking is difficult to tease out on CPRS, but using this algorithm, we were able to get current non-smoking and former smoking. And there's a big difference in survival in the patients that are current smokers versus former smokers and had an ultrasound screen and AAA diagnosis. Really, our study has some limitations. One is a retrospective study. It's a limitation. It's also a benefit to have a homogeneous cohort of mostly male veterans, because you can compare them well, and they have a high prevalence of smoking, but you might not be able to put all this data on other populations. As I was alluding, we probably, by limiting our AAA diagnosis to 0 to 365 days, we underestimated the true prevalence of AAA. And also, we don't count that there may be incorrect billing codes in terms of the patient that had a AAA screening or actually a AAA diagnosis. So in conclusions with this study, we can say that the implementation of AAA screening was associated with improved survival and a higher rate of AAA diagnosis. These findings provide further support that to continue the program at the VA versus just defaulting into an incidental recognition following other abdominal imaging. I wanted to show that how our data correlates well with what has been reported. So this is the EVAR-1 trial, and this is the 15-year follow-up. So how we do a really good job in preventing aneurysm related mortality, either with open or endovascular repair. But unfortunately, as I was saying, our patients still died with mortality at 5 years of 30% and greater than 50% at 10 years. So that's an area where we need to work in using AAA screening as a cardiovascular disease screening and get these patients some best medical therapy. What is next for our project? So we want to look at the imaging redundancy in screening. So a lot of these patients, when they got the screening, they had a previous aortic, either a CT/MR or a previous ultrasound. It's been reported that in aortic screening, there's a redundancy of 20 to 31%. So we want to see that at the VA to improve costs and value on aortic screening. We want to look at the use of best medical therapy in the screening population. I think this is an area, as I was saying, that has a lot of potential and where we can have a larger impact than solely treating the aneurysm per se. Obviously, we want to work on evaluating the AAA sizes. We might need machine learning for this, but we're going to work on that. We want to look also at overtreatment and based on the AAA sizes, how many aneurysms smaller than 5.5 were treated. And also look at what I show you, that big regional variation between centers and how to improve the implementation on the centers that they didn't have a good uptake of AAA screening. Thank you very much.
All right, thanks so much, Manuel, and great analysis, very interesting results. So everyone, please go ahead, and if you have any questions, go ahead and type it in the Q&A or raise your hand, and we can call on you as well.
I'll raise my hand. This is Oliver. Just real quick, thanks again for the opportunity, Ryan, and the PHIND Center for the, for supporting this research. I mean, there's a lot of overlap with early diagnosis. I know there's a lot of interest in doing a cost analysis as well, but I guess the overarching theme seems to be, that screening is a marker for, best medical optimization and kind of a marker for cardiovascular, or at least for aneurysms, for medically optimizing these patients. And I wish we had better, we could get better data on smoking and to see if it's actually true, to validate that, yes, the patients that were screened were, ended up being patients that were not smoking as much and were medically optimized. But it's also fascinating and interesting to look at, how frequently the AAAs are found incidentally versus with the ultrasound screening and kind of the divergence in outcomes between the two groups. So I don't know, Manuel, I wish there were, I don't know if you have any, if there were strategies that came to kind of dig a little deeper into the, medical optimization question between the two groups. I don't know if you had other strategies or not.
I mean, I think, Oliver, yeah, no, what you said is true. And so for I think, I mean, starting with just medications on these patients to see how compliant were, or if they were starting on antiplatelet and statin, and compare that to the other cohort that we have with other abdominal imaging. If that was a big, because actually, I mean, the effect on mortality is big. I mean, we were not expecting to have that big difference on mortality in the patients that had a AAA diagnosis. So we want to just try to find out why that happened.
I love it. And I'm wondering if for everyone listening, if you could just talk about the cost difference between an ultrasound and a CAT scan, if you know offhand, because that's a pretty big dramatic, there's a difference there as well. I'm sure it's hundreds of dollars, or yeah, maybe a few hundred versus almost 1,000, depending on where you get the CT done, potentially.
Well, that, and then I mean ultrasound screening, all the cost effectiveness analysis that have been done have shown that it's a cost effective strategy.
Perfect. Brian, do you have any other questions, or anyone else?
Yeah, I mean, I have some questions. I mean, it was interesting. You said, there was a lot of variation between the different centers, and I know you guys are, you're planning to look into that. I mean, what do you think the key drive? You just speculating. What do you think the key drivers? Is it the physicians aren't utilizing it when they can? Is it because the patient populations aren't going and utilizing it? I mean, it seems like you mentioned a lot of CPT codes and reimbursement, and you're showing, it basically, the data is very encouraging. So it'd be great to get your thoughts.
So I mean, and yeah, and it's interesting because at the VA it should be the same, right? I think part might be looking at because Northern California has one of the best implementation of aortic screening, and what they took it up on themselves of sending the radiologists and vascular surgeons to the population that was eligible letters to get them to get screened, and also the alerts to the primary care physicians on CPRS. I know the alerts go off on other centers, but they may not be that. It's not that they're not invested, but they may not have the same reminders as the other centers. I mean, people have looked at, for example, at lung cancer screening, and it's a combination of both of maybe sometimes if the center is too far away from the actual city, that people are hesitant to go to the center because it's too far away. Yeah, no, I think it's multifactorial, but definitely there's room for I mean, a lot of room for improvement in that regard.
And I also wonder, I think, the three of us, we've sat down and chatted about this multiple times, and, it's exciting to look into these things. And one thing you mentioned also was kind of the guidelines. And did you have any, there's optimization of kind of utilization with what's established. And then there's also, I guess, the guidelines of, what in general, what's practiced. Are you happy with how it is currently, or do you have, is there room for improvement there as well?
I think there's room. I mean, definitely with gender. I think the USPSTF has been because I mean, the trials first there was only one trial that included women, so that limited the data, right? But that doesn't mean that women are not prone to develop, and actually they rupture more often than men. So I think the aortic screening should include men and women equally, and that recommendation should be changed. The Society of Vascular Surgery, they recommend actually screening both. I mean, I agree with the history of smoking because that's a big driver of it. But there are countries in Europe that actually screen everyone above 65. Definitely with that, your strategy is not as cost effective. But I didn't mention it. There's a trial done in Denmark, the VIVA study, that what they were trying to screen for cardiovascular disease. So they were doing aortic screening, looking at hypertension and an ABI, so an ankle brachial index, looking at to PVD. And when you screen for cardiovascular disease, they actually were able to find a difference in mortality because just by giving the best medical therapy. So I mean, right now in the U.S., the only screening strategy we have for cardiovascular disease is actually aortic screening. There's no ABI screening. There's no screening for I mean, definitely for not for coronary artery disease, and we don't screen for hypertension. So we only have aortic screening. So we should use that that tool that we have right now to improve the medical therapy of these patients.
I think what needs to be mentioned also is that the medical, I know in vascular surgery, for example, in the area of carotid disease, the studies that we kind of use to make our clinical decisions are really old, and the medical management has improved so much that the outcomes, and they're just so effective, that the medical management, that this again just supports further, just being better about identifying cardiovascular disease, since we can, improve the risk with better medical management. So that's a great point, Manuel.
So we also had a question just came in. Do you think portable ultrasonic probes can help the screening?
So that's a great question. So there are studies on that from Australia and Europe, and I think it definitely has a role. You only need the operator to know what they're looking at, right? So I think the training is not that hard, but if you're, I mean, especially now with the new technology, like the butterfly ultrasound that you connect to your cell phone, that we will be able to in primary care settings to identify these aneurysms. The problem is that how do you make sure that that gets into the electronic medical record and it gets followed, right? I mean, when we were looking at the other abdominal imaging, I'm sure that those aneurysms, they probably were reported, and they were in the radiology study aneurysms, but because it was not, whoever ordered the study was not actually looking at the aneurysm, so never got into the electronic medical record as a AAA diagnosis, right? It's only when you're actually ordering a AAA screening. So yeah, I'm not saying that CT is worse to diagnose, actually the other way around. I think CT is great to diagnose a AAA. It's just that when you're not looking at it, it just gets missed.
And I think the other thing you mentioned was, improving it so it doesn't get missed, having some kind of AI machine learning, looking at the data. Are you also thinking about that cutting across the other imaging modalities, like having MR and CT?
Yes. Yeah. I think that would be a great second project. Yes.
Excellent. Oliver, any others that have any other questions?
Yeah, no, I just want to second what Manuel said about the point of care ultrasound. I think ultrasound's amazing. In fact, I wish dialysis technicians would use it when they're accessing, AV fistulas grafts. They're now so ubiquitous through, these mobile portable devices and so on. I think it's phenomenal, but it's really hard. It's so dependent on the operator. That it's really hard to teach and train, and to kind of make sure everyone's looking at the same thing with their studies, and also to close the loop with the informatics piece is super, super important, which I don't think we do a great job with today. But I just want to overall say it's a fascinating, study, and really highlights what I think is, I believe, I work in a VA center, so I know that even though VA is a VA, it's the people and the people running the day-to-day clinics and so on that dictate the protocols actually being implemented. So I think there's room to, for standardization and to have clinical pathways and to kind of, improve quality overall. It's a huge opportunity. I mean, the numbers are, dramatic that Manuel's research has brought out. So I think, just again, this points to more policy and so on improvements, and expanding the screening. But I'm glad to see their great opportunities. And I don't know if Manuel can speak to the U.S. Prevention Task Force. Unfortunately, I don't know if something like this would even change their recommendation guidelines. I don't know if you want to comment on how they make decisions.
Yeah, it is usually with level 1 data. So they do look at cohort studies. Like, for example, that like last time was, a year ago or 2019, what they do is they make the recommendation, but there's also a group looking at all the data. I mean, they do a great job. And I actually spoke to Doug Owens when we were doing this. I mean, and he was working actually on the guidelines, and I mean, he was working also with a couple of researchers from Kaiser, and this change in I mean, these findings, what they may promote is actually creating new trials, right? So and then based on that, you change the guidelines.
Excellent. And any other questions, anybody? Well, I think, this was really informative. I think really interesting data, encouraging data. Looks like you have a lot of great future directions for improvement. So thanks so much for sharing that with us. We look forward to kind of seeing that as it continues to roll out. And yeah, really great work, and look forward to working with you guys as part of PHIND moving forward.
Thank you very much, Ryan. Thanks for all your help.
Yeah, likewise.
Thanks, Ryan.
Mm.